Dear chairpersons, ladies and gentlemen, it's a good honor for me to speak to you about the key recommendation by a PASO clinical practice guideline on the diagnosis and management of patients with PBC. Recently, PASO formed a group of experts, drafted and finalized the guidance on the management of PBC. Due to the limitation of time, I will not go through everything of this guideline, but I will focus the epidemiology, diagnosis, management, and special considerations of this disease. First of all, let's look at the epidemiology of PBC, which was thought a Western disease. Indeed, from this meta-analysis conducted by my co-workers, we can see that the prevalence of PBC was most prevalent in North America, also prevalent in Europe countries. But in Asian Pacific region, we also have this kind of disease. Among Asian Pacific region, the epidemiology also a variable. From these slides, which derived from another meta-analysis by my co-workers, also show that the high prevalence reported from mainland China and Japan, the medium prevalence reported from New Zealand, whereas the low prevalence reported from Australia and South Korea. Does this really mean the true difference in prevalence, or just because the reporting bias is not very clear? Therefore, population-based epidemiology on PBC in this region is still needed. Now, let's look at the major manifestation of PBC, which is mainly affects the women, middle-aged women, clinically manifested as the intrahepatic cholestasis, as shown by elevation of ALP and gamma GT. Specifically, most of the patients have a positivity with anti-mitochondrial antibody M2, GP21, or SP100. Then histopathologically, the non-purulent interlobular cholangitis is evident. Finally, treatment with UDCA usually have good response. For second-line therapy, obeticholic acid or fibrates will also help. So this is the brief overview of this disease. For the diagnosis of this disease is relatively straightforward. We can see that if two of the following three criteria are met, the diagnosis of PBC is established. First is biochemical evidence of intrahepatic cholestasis, shown by elevation of ALP and gamma GT, with exclusion of extrahepatic biliary obstruction by ultrasonography or other imaging studies. Then the serum positivity of AMA or SP100 or anti-GP210. Lastly, histological evidence of non-suppurative destructive cholangitis, mainly affecting the interlobular bowels. Any two of these three met, then we can make diagnosis of PBC. So this slide is showing the supporting evidence of why we see anti-GP210 and SP100 also recommended for diagnosis of PBC. This is simply because they have very high specificity for the diagnosis of AMA negative PBC. This meta-analysis also conducted by my co-workers, which show that the specificity of both of these are over 95%, although the sensitivity is relatively low, around 23–25%. Now, let's turn to the therapy. So the first-line therapy, the treatment choice of all PBC patients is UDCA, also deoxycholic acid, which is standard of care worldwide and recommended by all the international guidelines on PBC. The your dose is 13 to 15 milligram per kilogram body weight per day for all patients for lifelong time. Then it is recommended that evaluation of the UDCA response, we call biochemical response, at 3 months or 12 months of UDCA treatment is recommended. The aim is to identify those who does not respond well, we call suboptimal responders to UDCA, who need the second-line therapy. Now, that's the second-line therapy. The first is recommendation is obeticholic acid, OCA, which is approved for the PBC in Europe and America. It should starting at a very low dose and titrate to higher dose because it has a very prominent side effect, pruritus. If it's well tolerated, we can increase to 10 milligram per day after several months. Then this is add-on therapy. Of course, it can also use as a monotherapy if patient cannot tolerate to UDCA. Although this kind of patient is very rare because UDCA is well tolerated in most of the patients. One note is that potential risk and adverse effects of obeticholic acid should be discussed with the patients because this kind of patients need to be carefully monitored. Now, I just show you some key evidence supporting the recommendation of obeticholic acid. This slide is showing that the pivotal phase 3 clinical trial called POISE. From this RCT, we can see adding OCA to UDCA for 12 months in PBC patients who had a suboptimal response to UDCA monotherapy. We will have improvement in biochemistry in terms of declining ALP and bilirubin. So they clearly showing at the different dose of OCA have a better efficacy than placebo. Now, similarly, OCA can also be used as a monotherapy, which could also improve the ALP and gamma GT in PBC patients who somehow cannot tolerate the UDCA, although it is very rare. We can see this the left panel showing the changes of gamma GT, the right panel showing the AST. For both gamma GT and the AST could be improved by treating with obetic acid. This is actually from this slide, we can see the 10 milligram and 50 milligram. Actually, the efficacy of 50 milligram is not as good as 10 milligram. The reason is that the higher dose had a more adverse effect, especially pruritus, that will cause more patients stop the medication. Therefore, in the future guideline, and the current guideline, we recommend a very low dose, does not use the 50 milligram, which is too high and cause so many adverse events that actually compromise the efficacy of this medication. One note is that OCA, obeticholic acid, will increase the risk of decompensation in cirrhotic PBC patients. We can see from the left panel, the decompensation rate is increased compared with those not use the OCA. Although the liver-related death or liver transplantation rate is, does not differ across these two treatment arms. So for patients with cirrhosis, especially those with decompensated cirrhosis, OCA is contraindicated. Some other second-line therapy used as off-label use for like benzofibrate or fenofibrate, which both of these are used to treat hyperlipidemia which mainly decrease the triglyceride. Now it is used as a off-label. You can see either of these could be used as a combination therapy with UDCA for those who have inadequate response to UDCA monotherapy. Again, adverse events should be closely monitored, especially in those with cirrhosis. Then Potassonite, which is a corticosteroid with a very significant first pass effect in the liver. That means less exposure to the system. So it is effective for liver disease, but with less side effects in the whole system. Again, this should be used in non-cirrhotic patients because this disease may increase the incidence of portal vein thrombosis. So this is the evidence supporting the use of benzofibrate adding to UDCA. You can clearly showing that's the ALP. You can see after adding the benzofibrate, the ALP declined, whereas in placebo group, there are no significant improvement. This slide showing a meta-analysis demonstrating the fibrates, including benzofibrate or fenofibrate, can improve the serum biochemistry. Here, I just show the data on the ALP. You can see both of these could improve the biochemical response in patients who with suboptimal response to monotherapy of UDCA. For those already at the decompensation stage and failed to respond to the first line or second line therapy, liver transplantation is the ultimate solution. It is recommended for patients with a Mayo score higher than 15 or Mayo risk score higher than 7.8, or patient with severe intractable pruritus. Then the post-transplant UDCA treatment is also recommended for prevention of PBC recurrence. Now, a few words about the SCC incidence of PBC patients in our region. We can see this slide also derived from meta-analysis conducted by my colleagues. Then the 5-year and 10-year incidence of SCC in PBC patients is not very high. Probably is lower than that in the viral hepatitis like hepatitis B or hepatitis C patient, but it did occur. Therefore, we recommend the SCC monitoring in patients with advanced disease, has cirrhosis with female, and or non-responding to UDCA. So this slide just showing male, older age, and cirrhosis are risk factors for development of PBC patients. There is no difference in survival in prognosis between PBC-related and HBV-related SCC patients. Then last few minutes, I would like to talk the recommendation on the management of isolated AMA positivity. That means positivity for AMA, but normal serum test. For this kind of patient, we can follow up, give a close follow-up, or we can do the liver biopsy if they have elevated IgM or high titer AMA or ALP level close to upper limit of normal. Try to identify early stage or pre-phase cirrhosis. This recommendation is based on the several studies showing that for these kind of patients have PBC, have AMA positive but normal ALP, if you follow up for longer time, the incidence of PBC is relatively low. So we cannot give the diagnosis for all patients at this stage. Very last, we have the recommendation on the management of pregnant women. Pregnant women can be advised. Pregnancy can be advised in PBC patients, but if they have cirrhosis, of course, we need to pay much more attention. And during pregnancy, they can still use the UDCA, although the data is not so many, we can see the meta-analysis showing UDC does not increase the prevalence of stillbirths in women with intrahepatic cholestasis of pregnancy, not PBC, but the efficacy, the safety is the same. Then for the breastfeeding, there are only some case reports. You see that the level of UDCA in the breast milk is very, very low. Therefore, it is believed the breastfeeding of patients with PBC and receiving UDCA is safe. So lastly, this showing the slide showing the also this guidelines from across this region to also from China mainland and one from Egypt, from Turkey, and three corresponding also two from Japan, Professor Omata and Tanaka, and of course myself from mainland China. I would like to thank you for your attention and wish a great success of this episode Oncology 2021. Thank you again.